Introduce the next speaker, Dr. Choi Chan from Singapore, who's going to talk about new perspectives in inherited retinal dystrophies.
Good morning to everyone. Namaste. Thank you very much to the organizers for the kind invitation to speak today. Today I will be speaking on new perspectives in inherited retinal dystrophies, or what we commonly know as retinitis pigmentosa, or RP. And these new perspectives are actually based on advancements in genetics and therapeutics. I'll be touching on polygenic and modifier genes, non-coding variants, and this will lead to new approaches to gene therapy. Now, traditionally, we've always said IRDs are monogenic disorders. That means mutations in one single gene lead to this problem, the clinical phenotype. But now there is a thinking about polygenic contributions in IRDs. That means IRDs result from the combined effects of multiple genes and not just one gene, each contributing a very small effect. And this can explain why the clinical phenotype can vary widely among people with the same primary mutation. Now, what about modifier genes? Now, modifier genes do not cause disease directly, but they influence the severity, the progression, as well as the onset of the primary disorder. So I'm going to give you an example of a modifier gene. We all know RPGR. This causes X-linked retinitis pigmentosa, as well as X-linked cone rod dystrophy. Now, there is a mutation in RPGR IP1L which affects the severity of these conditions. And how does it do so? It is a modifier. It interacts with RPGR and the ciliary transition zone of photoreceptors, and it's also linked to ciliopathies like Joubert syndrome and Meckel syndrome, which have overlying features with RPGR disorders. So what does this mean for us as a clinician is that when patients have the RPGR mutation as well as a mutation in RPGR IP1L, this means this patient with earlier onset or more severe disease compared to someone who only has a mutation in RPGR. And this also means that when we do genetic testing, don't just stop when you find RPGR. You need to look for this other mutation in RPGR IP1L that will help us guide to the patient and advise them about how severe their disease might be. Now, something else about coding mutations. Now, we always think that IRDs are linked to coding mutations in genes which are responsible for photoreceptor and retinal function. But now, non-coding variants, which occur in regions of DNA that do not directly code for proteins, can regulate gene activity. So I'll give you some examples. There are intronic variants, which disrupt splicing. So this creates or removes splice sites in the DNA, leading to abnormal mRNA and incorrect protein synthesis. That could be promoter variants, which affect transcription, as well as enhancer variants, which affect post-transcriptional regulation. So examples are CEP290. Now, mutations in CEP290 cause a very severe form of RP called Leber's congenital amaurosis 10. We now know that an intronic variant in intron 26 of CEP290 causes a cryptic splice site, leading to defective proteins. And it's very exciting because this can be treated with antisense oligonucleotide therapy, and I'll talk more about this later. Another one is USHA2A. This is one of the commonest variants that we have in our Singapore database. And this deep intronic mutations in USHA2A leads to exon skipping and therefore defective proteins. And the last example I have is PRPF31, which causes autosomal dominant RP. They have regulatory variants in the promoter region there, which affect gene expression. So all this talk, polygenic interactions, modifier genes, non-coding variants, what are the clinical and therapeutic implications for us as clinicians? Number one, it can actually help us solve cases where we don't find a causative mutation. I have so many cases where the patient has a clinical phenotype, but we can't find a gene. So these interactions here could explain it. And it also means, we always use panels, not next generation sequencing. That may not be good enough. We should think about whole genome sequencing as well as RNA sequencing to identify these variants. And this explains why even amongst the same family, same primary mutation, why the disease severity can be different. And what about how it affects therapeutics? There would be CRISPR-based gene editing as well as antisense oligonucleotides, which can be used. So I'm going to jump right into that now. So the strategies we have for gene therapy is, traditionally, we all know, add the correct DNA to the cells of the patient. This is called gene augmentation. And the best example of this is Luxturna, okay, or RPE-associated LCA. The next one we can do is we can modify the patient's DNA. So this is gene editing, and a good example is CRISPR or Cas9. And the third example is at the RNA level with antisense oligonucleotides. So Luxturna, which I talked about, is very specific. RPE65, we just treat that mutation. How about a gene agnostic approach? Okay, so that means it doesn't matter what the gene is. So Ocugen, the company, has come up with this product called OCU400, and this is an injection of an adeno-associated virus carrying the NR2E3. Now, what is NR2E3? It is a major retinal transcription factor involved in photoreceptor development. So by injecting it, it protects against photoreceptor damage. Now, there are mouse models that have proven this, and they have done phase 1-2 clinical trials where 16 out of 18 patients had ERG improvement. And now there's a phase 3 trial with 150 patients. So let's see what happens there. Now, genome editing actually targets DNA sequences, and the best example of this is CRISPR-Cas9. Now, this stands for clustered, regularly interspaced, short palindromic repeats, and it was such a revolutionary idea that the two scientists who discovered it won the Nobel Prize for this 3 years ago. So what we have here is you've got the guide RNA in orange, and it brings the Cas9, which is the endonuclease scissors, to the correct place in the DNA of the patient. And this inactivates the genes, and this is great for treating autosomal dominant gain-of-function mutations. For more precise editing of the genes, you can put in a DNA template, and this will correct the underlying gene defects. So a very good example is in CEP290-associated Leber's congenital amaurosis. Now, there is a deep intronic mutation, the IVS26, and this is in 60% or more of patients in the US and the EU have this mutation. So if you look on the left column, all right, this is the disease. There is this IVS26 there causing a pseudoexon, which is the red cross between exon 26 and 27. Now, this pseudoexon causes a premature stop codon, and we don't have the protein being produced. So Editas came up with the Edit 101, which is an AAV vector containing 2 guide RNAs on both sides of the incorrect of the intronic mutation. It cuts it away, and by cleaving it, you get rid of the pseudoexon and leads to the production of the functional CEP290 protein. And this was it was published in New England Journal of Medicine, and this was the Brilliance CRISPR clinical trial. What about antisense oligonucleotides? These are very small, single-stranded RNA or DNA sequences, and it targets mRNA. So with the next step now, it alters the mRNA splicing, inhibits translation, and silences the gene. And therefore, it can be used for gain-of-function mutations. The advantage is it is an intravitreal form of delivery, something we're all very familiar with. And as a result, it is easy to use, but the disadvantage is you need repeat dosing. So here are the 2 modes of action. One is with gamma or RNA degradation. So here we have the ASO forming a duplex with the patient's mRNA, and the duplex is recognized by the RNase enzyme which cleaves the mRNA, and you don't have the abnormal protein formed. So one example is in rhodopsin P23H mutation. What about the other form of ASO with splice modulating? So here we have the ASO removes the pseudoexon, which lies between exon 3 and 4. And an example of this is in CEP290. This was published in Nature as well. And it's also very, very good for ABCA4, which we know is too large to fit within the AAV vector. So this is very elegant. The other example is how ASO removes the in-frame exons, causing truncating mutations, and therefore you have the normal protein formed. And this is used in USHA2A. Now, the next step is stem cell regenerative medicine, because sometimes the IRD is too far advanced, so there's stem cell therapies. So again, Yamanaka and Gordon, they received a Nobel Prize for this technology, where they reversed mature cells all the way back to pluripotency by infusing it with Yamanaka factors. And we've tried this in macular degeneration. This was published in New England Journal, and they have put in autologous-induced stem cell therapy for macular degeneration, but they're hoping to expand this to patients with IRDs. And optogenetics is also very exciting. This is published in Nature about 2 years ago, and this is repurposing other retinal cells, such as retinal ganglion cells, into new photoreceptors. And this is genotype agnostic, possibly disease agnostic, and is very promising for end-stage IRDs or acquired disease. And this is the proof of concept that was published. So this is all very well. Take a step back. You see, that sounds great, but that just sounds too far-fetched for me right now. It's not going to happen to my patients. So I'm going to give you my own patient, an example. I saw her just 2 weeks ago, a 35-year-old Malay lady, newly married, with nyctalopia since her 20s. She has this phenotype. Now, always we think RP, you have to see spicules, but I wanted to show that actually you don't have to see spicules all the time, but the autofluorescence, very obvious changes on the white field. Her corresponding OCT shows disruption of the EZ layer. And her field's already like this when she's 35 years old. So she wants to have kids, but she's very worried. What's going to happen? So if you look at her, that's her with the arrow there. Her mother, and her father, how do I go up? Her mother and her uncle went blind from the same disease, but I've not seen them, so I'm not sure, but she told me they went blind. So what did I do? I sent her to the genetic counselor. We did genotyping, and she was found to have a pathogenic variant in the TOPORS gene, which causes autosomal dominant RP. Now, very interesting, she also had other genes. She was found to be a carrier of JB2 related hearing loss. She had variants unknown significance in RP7, but the one causative variant was the TOPORS gene. So what did we do for her? We talked about pre-implantation genetic testing, which is a screening test performed on embryos created via IVF. So how does this work? First, we get the genetic diagnosis, we have that. Next, she has to go through IVF, and once you have the blastocyst at first week, we take some cells from that blastocyst, we analyze it to check whether they carry the mutation, and we only implant the mutation-free, unaffected embryos back into her womb. And that's, we may want to do prenatal testing with CVS or amniocentesis before the pregnancy is completed. Lastly, I just want to add, there's more to it. There's AI and deep learning, which might assist with IRD management and precision medicine. So this is a very, very exciting space to watch. So previously, all our patients with IRD, we always tell them there's not much hope, but I hope that with my talk, we get some new perspectives on how to manage our patients with IRDs. Thank you very much.